Hello, I'm Melanie Riley and I'm the metastatic breast care nurse at Breast Cancer Care WA, and I'm joined with Dr. Chandrika Gibson, and we're here today to present the third in our series of wellness webinars, specifically for people affected by metastatic breast cancer. This series is looking at complementary and integrative therapies and how they can be used to help with some of the symptoms and side effects that people can experience as a result of their metastatic breast cancer. We've previously looked at a general overview of complementary therapies, and we've also looked at how they can help ease menopausal symptoms. And the main focus of our webinar today is going to be on pain. This can be a big issue for people living with metastatic breast cancer, and there's a variety of pain that they may experience: lymphedema, peripheral neuropathy, bony pain, just to name but a few. So we're going to cover some of those today and look at alternative options to help manage that pain other than pharmacological interventions. Just a few housekeeping things before we begin. So while you're watching this webinar, if you do have any technical difficulties at all, please call our reception on 9324 3703. That's 9324 3703, and then we'll try and help you through that process. We welcome questions throughout this webinar, but we will wait until the end to answer them. There on your screen, you should see a little chat box, and it's either at the top of your screen or at the bottom, depending on what device you're using. So anywhere throughout the webinar, if you do have a question that you want to ask, just click on that, type in your question and send it, and we will address them at the end. If you can't do that or you don't feel comfortable asking it in this setting, then at the end of this webinar, there will be an email address that you can direct those questions to. And you can also always ring Breast Cancer Care WA and they can put you in touch with someone that can help you. We are recording this webinar and it will be posted on our website a couple of weeks after today. And that's the reason that we're just keeping your identities from the screen in case you don't want that shared. At the end of this webinar, we will also send out an evaluation, and if you could complete that, it would be really helpful, just so we know if we've covered everything that you want to know and whether there's any topics that you might want to see in the future. So we're just going to go through the learning outcomes for today. So at the completion of this webinar, we are hoping that you will understand the prevalence and different types of cancer-related pain. We hope to give you a basic understanding of the medical management of pain. We hope to help you recognise the limits of conventional pain management, have an understanding of evidence-informed lifestyle strategies, and be familiar with evidence-based complementary and integrative therapies for managing pain. And facilitating today, so as I said, I'm Melanie Rowley. I'm the metastatic breast care nurse at Breast Cancer Care WA, and joined by Dr. Chandrika Gibson, who will be presenting the information. So just a little bit of background on me. So I qualified back in 2004. I trained in London, and then I worked at the Royal Marsden Cancer Hospital there when I qualified and completed my postgraduate diploma in oncology and nursing then. I then moved to Australia in 2009, and I've always worked in cancer care since then. So I've got a range of experience with caring for people undergoing chemotherapy, radiotherapy, endocrine therapy, immunotherapy, and I've also done some work in palliative care as well. And then presenting for us today, we have Chandrika Gibson. Chandrika's worked extensively in cancer since 2006 in a variety of roles, including the Cancer Council, Cancer Support WA, Solaris, and now very lucky to have her with us at Breast Cancer Care WA. So Chandrika helps evaluate and devise education programs for people affected with cancer to reduce suffering. And she does that by combining her understanding of psychosocial issues, supportive care, complementary and integrative therapy with her skills in research and writing. She has many strings to her bow. So she is a qualified yoga teacher and senior yoga therapist. She has an advanced diploma in naturopathy and a Master of Wellness, and she's very recently completed her doctorate. So she's got a wealth of knowledge and experience, and we're very lucky to have her presenting with us today. And on that note, I will pass over to Chandrika.
Thank you very much, Mel. Okay. So I'm going to start with a little bit of background on pain science. It's quite a fascinating topic. Obviously, we can't go in depth into everything in this session, but hopefully enough to get you thinking about your understanding and your experiences of pain in your life. So it's always good to define things straight up. And the definition of pain, according to the International Association for the Study of Pain, is that it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So already in that definition, you can get a sense that this is a mind and body experience. It can be a very emotional experience. And mind and body are always interacting, as I'm sure we understand from our lived experience. And so some of what we'll look at today in terms of the complementary and integrative therapies are things that help you manage stress, things that help you manage fatigue, things that help you manage your own mind states, because that has a big impact whether or not we can remove any physical causes of pain, which in the case of metastatic breast cancer, that may not be possible. So that really is why there's such a useful space here for the more complementary and integrative therapies to be used. Pain is always deeply personal. And so right out of the gate, I want to acknowledge that whatever we are talking about in terms of pain may not be true for you, and not everything that we suggest will work for every person. It's really unique. It's influenced by biological factors, psychological factors, and also social factors. There's a difference between a pain experience and nociception. So nociception is what you might remember from school or, earlier in your life, that image of when you touch the hot thing, that impulse runs through the nervous system to the brain and you reflexively remove yourself from that pain. That's nociception. But pain is not just coming from those sensory neurons. In fact, our whole nervous system is involved in generating and continuing the messaging around pain, which again is why we can intervene with some mind-body processes. Pain can also be quite learnt. Our histories matter, our life experiences matter. If you're a health professional, which I know some of you are, it's important to remember that it is so subjective and we can't ever really understand somebody else's experience of pain. So if pain is reported, we have to take that seriously and respect that that's that person's experience. Pain in its ideal form is adaptive. It lets us know that there are signals of danger, either externally in the environment or internally within our bodies. However, it can become maladaptive. Sometimes it has quite adverse effects on our functioning and on our social and psychological well-being as well. It's also interesting to note that even if you can't communicate verbally, there is still likely to be a pain experience. It doesn't need to be expressed in words, in human language. There are different types of pain. You might be familiar with acute pain and chronic pain. That's really to do with time limitations. So acute pain is that normal adaptive response to some kind of noxious stimulus, some kind of input, which is resolved when the input is gone. Subacute pain is when that doesn't resolve as quickly as one might expect. It might be starting to progress towards a chronic state. Some pain experiences recur, they come and go like waves. Cancer pain, self-evidently, relates to the underlying cancer pathology. And chronic pain is usually defined as pain that lasts for 3 months over a 6-month period, or that it persists beyond the usual course of healing that would be expected if there has been a physical injury. So chronic pain might be something that we're looking at in metastatic breast cancer, either because that noxious stimulus hasn't resolved, hasn't gone away, or because our nervous system is contributing to continuing the messages of pain. And that's again where some things we can control or alter, some things we cannot. We have to accept and manage and live with. So what makes it more likely for pain to become chronic is our own thinking patterns. Catastrophic thinking, where we take the worst case scenario and run with it. That increases our subjective experience of pain. That doesn't mean that we have to be positive all the time, and it doesn't mean that we should never worry. These are all part of the full catastrophe of life and life with cancer. But we can check ourselves when our thinking is maybe getting out of control or unrealistic. Similarly, the more anxious and fearful we are about our pain, the more intense it will feel. You may have seen, if you go on YouTube, Lorimer Moseley, one of the leading pain researchers, a thought leader in this space, describing bushwalking and getting a scratch on the leg that turns out to be a snake bite. And so when you have no fear and that scratch on the leg is simply a twig, the pain experience is much less. But when it's potentially life-threatening, like the snake bite, of course, the feeling of pain becomes intensified. In a similar way, the more our stress levels go up, the more we create this kind of psychoneuroimmunological setting where our bodies become very inflamed and our minds become really alert to danger, and we're not switching off, we're not having that relaxation response. So again, that's where some of our complementary and integrative therapies intervene. It's also interesting to note that helplessness increases the risk of chronic pain. And so this is where complementary and integrative therapies can feel really empowering, because these are things you can largely do for yourself, or you can choose from providers in the community. If you can become more self-efficacious, if you can do more for yourself, that decreases the pain experience and the risk of pain being prolonged or intensified. If you can have some healthy pain coping strategies, like some of the things we'll talk about today. Exercise, for example, is an active coping strategy. It might not be the first thing you think of doing when you're in pain. It's a bit counterintuitive, but it can really help. So can distraction. You don't have to always be mindful of what's going on. Mindlessness has its place too. Approaching life with a sort of psychological flexibility so that you can be ready to change your goals, not to change your values, but to change the way that you enact them, and to accept the suffering that might be there in your life. Easier said than done, of course. Unfortunately, these pain experiences do have a multifactorial effect on us. Pain goes along with a number of other conditions or comorbidities. For people with chronic back pain, which is only one example of the kind of pain you might experience in metastatic breast cancer, depression occurs in up to 80% of people. Again, these are averages from studies, so it doesn't mean it has to be going along with pain, but it is common to feel depressed. It's also common for people with pain to experience more cardiovascular disease and more lung conditions than their pain-free peers. But depression is really the most common emotional consequence of pain. And these multi-morbidities or comorbidities also place a strain on health systems, meaning that you need more support. So we're hoping today to give you some strategies of things you can do for yourself. But of course, that doesn't mean you stay out of touch with your health professionals. We definitely want you to keep informing them of everything that you're choosing. And I guess that's our disclaimer when we talk about complementary therapies as well, is that it is really important that you keep the lines of communication open with all of your health professionals. So one explanation for these comorbidities, in particular depression in pain, is this fear avoidance model. And obviously this has injury as its starting point, and cancer isn't an injury per se, but that pain experience is there in the centre. And when we find ourselves in this nervous system state of catastrophic thinking and fear, then we tend to avoid. We tend to freeze up and try not to create more pain. You might find that there's one particular body posture that you can take where the pain is lessened, and it makes you avoidant of doing other things in your life. It also makes you mentally and emotionally hypervigilant for threats, and that's happening on the biological level as well. Your immune system is primed for threats. So when we're in that avoidant and hypervigilant state, we tend to lose body conditioning because we're not moving as much. We're not doing the things that we would normally do, and that increases depression and disability. Whereas if you spiral the other way in this kind of flow here, from that central pain experience into a state of acceptance and less fear or no fear, and an ability to perhaps confront or move into some of that pain experience, not avoidance, the opposite, leaning into suffering, which seems, again, really paradoxical, I know. But that tends to lead, if not to full recovery, but to a recovery of what matters to you in your life. And so it's really important that we try to understand for ourselves what that might look like, because it is going to look different for everybody. One thing I would bring to your awareness, though, is that even though we're going to encourage you to be as active as you can be, you do need to be mindful of this typical pattern that happens in pain that's known as the boom and bust cycle. Because we don't feel like moving when we're in pain, or we feel like we have to protect our bodies from further pain, and we freeze up or we go into hibernation and stop moving. Then when we do start, sometimes we start with the best of intentions. We set ourselves a new kind of goal to meet, and we do too much too soon. And that can typically create a kind of flare up in our symptoms, leading us to then be incapacitated again, and we're on this roller coaster. So the idea is not to do the boom bust pain cycle, but to do a small amount every day. This is particularly with exercise. And in the case of metastatic breast cancer, you may need that to be supervised initially, to have a program developed for you by a suitably qualified physiotherapist or exercise physiologist, so that you're working within a safe range of movement for you and getting stronger gradually, not increasing the load too much too quickly, particularly where there's bone mets and a risk of fracture. So unfortunately, a lot of the pain related to metastatic breast cancer is due to the cancer itself, which means that, in terms of complementary therapies at least, we may not be able to take away the cause. There may be medical interventions like radiotherapy that can shrink tumours and can help to minimise some of that pain. But from a complementary therapies perspective, we have to learn to live with and manage as well as we can by bringing down the nervous system hypersensitivity and triggering the relaxation response and getting in touch with our values and doing what matters to us. So the ways that the cancer can cause pain is if it's pressing against nerves or on the spinal cord. And this is often described as sharp or tingling, but it can also be burning or shooting, that kind of nerve pain that is really hard to live with. We know that it is incredibly uncomfortable, very, very painful, and hard to treat as well. And that's neuropathic pain. There can also be kind of visceral pain. The organs of our viscera in our torso don't typically give us that much sensory information. But if we take our awareness inward, or if we have a tumour that is causing organs to swell or pressing against different parts of the organs in the viscera and causing swelling, then we can have these sometimes quite elusive sort of aches, cramps, or they might be sharp or gnawing pains in our abdomen, our right-sided abdomen if it's liver related, maybe low in the abdomen if it's bowel related, and it can move around. So if the tumour itself can be treated, the pain can be treated in that way. Otherwise, we're looking at pain management. Now, Mel is more the medical knowledge base around here, so I'm going to keep this fairly brief about medical pain management. This comes from the World Health Organization guidelines for pharmacological and radiotherapeutic management of cancer pain, and they are recommending analgesia. So opioid medication, including having it in different routes of administration, rotating and taking pauses on medication to get the most effectiveness from it. Again, you'd need to speak to your medical professionals about the suitability of those approaches for you. There are also adjuvant medicines like steroids and also antidepressants, and some of the anticonvulsants like gabapentin, for example, that tends to work on nerve pain particularly. And then there may be some other medications related to your bones. So the bisphosphonates are to do with keeping your bones stronger. Is that right, Mel? Yep. And radiotherapy may be used to manage any bone metastases. But there are limitations to these pharmacological and radiotherapeutic approaches. So even when working within the ideal guidelines, pharmacological management of neuropathic pain only helps some patients, between 40 and 60%, to reduce pain by about 30%. So if you're scoring your pain a 9 out of 10, that might not be enough, really. It's something, but it's not necessarily enough. And then, of course, pharmacological treatments always do come with side effects. Side effects of opiates like tramadol, tapentadol may include sleepiness, drowsiness, might mean that you cannot drive, might mean that you can't do things that matter to you, might also cause skin itchiness or rashes. And these drugs do tend to slow down the digestive system, so there can be constipation and nausea associated with them. People do voice a lot of concerns about opioids, but they certainly do have a place in pain management. And so don't be afraid of them, but do this in collaboration with your health professionals. Steroidal treatments also can be quite stimulating to the nervous system. Some people find that it revs them up a lot, keeps them awake at night, and also might give them that kind of classical moon face or edema swelling. So back to understanding pain and how we can manage this from the top down, really, from our brain down. We can't necessarily take away the stimuli from the body, but we may be able to manage what our mind and our brain are doing about this stimuli. So there's a very interesting concept, this cortical homunculus, like the little person that lives inside your brain, that is a map that runs across both hemispheres of the brain, the somatosensory cortex and the motor cortex of the brain. And this map has all of your body parts in it. I think of it a bit like a kind of satellite that is creating your GPS, that's mapping your body in your brain all the time. And what you might notice looking at this image is that some parts of the body take up more real estate in the brain than others. The places in our body that have the most sensory nerves take up the biggest space. So our face and the sense organs of our head take up a lot of real estate. Our hands and our feet take up a lot of real estate. And so too do our genitals. So places where there's a lot of sensory input potentially. What happens in pain is that the area where the pain is starting from in the body starts to take up more and more space in this map, this homunculus. And so what happens is a thing called cortical smudging, meaning that it stops being easy for us to see clearly or to recognize which body part we're getting the experience from. So our mapping system is becoming skewed to focus more and more on pain. And this is where the mindfulness-based interventions really have their place. Things like body scanning, where you take your awareness from your head down through the whole body, slowly or fast. It can be done in different ways, down to your feet and back up again. And again, there's different approaches. You can do separate body parts. You can do this in a kind of rotation around the body. There are lots of guided resources for body scanning. But the essence of it is that you pay attention on purpose to what you feel without judging it. So you're trying to create a sort of detached observer state in your mind, whereby you're not believing everything you think, whereby you're not adding to the pain stories with more fear and catastrophic thinking. I know this is really difficult. It's really like exercise. It's a discipline for your mind to practice not reacting to pain. Yes, you can acknowledge it. We're not saying avoid it entirely. We're saying, yes, there's pain and there's other sensations, and I'm going to give them all equal attention. And that's how we make this map in the brain clearer, more accurate, and less biased towards those painful areas. And how it works is that it actually changes the way that our brain functions. You may have heard this term, neuroplasticity. And what it means is that we can always change. We can always adapt. We have a kind of default mode in our brain and in our nervous system that does things the easy way. Whatever we practice most becomes the easiest path. The saying is, neurons that fire together, wire together, meaning we create habits and they're shortcuts. So some of the pain educators, and again I'll mention Lorimer Moseley and David Butler, who have done a lot of work in the field of pain education, they developed this concept of the protectometer. And the protectometer is really a way for people to self-assess. What messages am I giving myself? What is my self-talk like? Am I creating more safety messages? That's the SIMs, safety in me, or more danger messages, the DIMs. And what happens is we experience more pain when our credible evidence of danger related to our body is greater than our credible evidence of safety. Now, I really do understand that living with something like metastatic breast cancer means there is a degree of danger that you're living with in your body all the time. But if we can put some emphasis on the safety messages, that may work, and this is what the science tells us, to bring down the experience of pain, to moderate it. So, in theory, we won't have pain if our credible evidence of safety is greater than our credible evidence of danger. Sounds easy. It's not easy. All of these factors come into play, and this is one of the important models of health, the biopsychosocial model. What we find in conventional medicine is still a hangover from an old school biomedical model. But even modern medicine appreciates the biopsychosocial factors relating to pain in particular. So we've got all of these things which may or may not be modifiable in breast cancer related pain, or the biological factors like the state of our tissues, the physical body itself, the inflammatory cytokines that might be circulating, our hormone status, and we may be having hormonal therapies, nociception, again, that nerve messaging of pain, our genetics, our sensitivity that's inherited. We may have things like peripheral neuropathies. We may have a lower or higher activity level, less or more sleep. Our medications might influence our pain on the biological level, our age, and other conditions. In terms of the psychological, sometimes it's about what we tell ourselves, our cancer-related beliefs, and when it comes to that fear of moving, our exercise-related beliefs and our pain-related beliefs. I said before, more worry increases the risk of pain. More self-efficacy decreases it. Our expectations about what lies ahead influence how much pain we feel. How health literate we are influences it too. And that's one of the purposes behind these webinars, is hopefully to help you increase your health literacy, to understand the science a bit more and to understand yourself and your health more, especially relating to cancer and pain today. Also, the image of your own body that you have, whether you think your body is strong and capable or whether you have quite negative perspectives about your body. The social factors are socioeconomic factors and your community, whether you have friends, whether you have an intimate relationship or friends that are close to you. The health professionals and the way that they relate with you are an important social factor in pain experiences. Sometimes they unintentionally give us nocebo messages. They tell us fear-provoking things. A good example is if you've ever been in a medical office where they've got a model of the spine and they show you what a slipped disc looks like, and then they tell you you've got this. That's fear-provoking. That's a nocebo. The opposite can also be true. We can have placebos, things that help us feel better even though there's no obvious mechanism for their working. Our relationships with our workplace, if we're working, our colleagues, our peers, might be our support group, friends. Our educational status, race and gender come into this, and so too do our cultural backgrounds, our ethnicity. So a note here about the way that Breast Cancer Care WA provides a biopsychosocial wraparound care model. We try to address all of these factors. Our breast care nurses focus on the body, but not the body alone. They help with treatment side effect education, physical symptom management, helping make informed decisions about treatment options, improving health literacy, helping people navigate the health system, and planning supportive care, including end-of-life care. Our counsellors also work with this kind of mind-body connection. They provide more of the psychosocial support for relationships. They can help you with your body image, your sleep, your stress, anxiety, fear, worry, all of that. They use a number of different person-centered therapies, which means they tailor them to your needs, including relaxation techniques like progressive muscle relaxation. Many of our counsellors are trained in mindfulness-based interventions, also in things like motivational interviewing, which can be helpful to kind of coach you along to do the right things for yourself. They all use the gold standard psychological intervention, which is cognitive behavioural therapy. But a lot of research shows that although that's very well proven, but very well evidenced, the third wave mindfulness-based interventions like ACT, acceptance and commitment therapy, are even more effective. They run therapeutic workshops and facilitate support groups, often in co-facilitation with a nurse or another health professional. And we also have our practical and financial support, which recognises some of the social factors relating to suffering in breast cancer. So you can apply or ask us for help with home maintenance, with childcare costs, with transport, and with bill relief. All right, moving into the next section of our presentation today. I apologise that I can't see you or anything in the chat box, so I'll get to any questions at the end. So I mentioned these World Health Organization guidelines. These are the pharmacological and radiotherapeutic management of cancer pain guidelines. Then in the US, there are a number of organizations that have cancer pain guidelines. The Joint Commission American College of Physicians, the National Comprehensive Cancer Network, and ASCO, the American Society of Clinical Oncology, all recommend that it's a really good idea to combine your pharmacologic and non-pharmacological modalities. And then we have the guidelines that have been pulled together from a huge body of research. And this has been brought to us by the Society for Integrative Oncology. And it's interesting that breast cancer was the first area of cancer, the first tumour type that they were able to develop these guidelines for, because there has been so much research in this space. So these are the clinical practice guidelines on the evidence-based use of integrative therapies during and after breast cancer treatment. So that applies across early breast cancer as well as metastatic breast cancer. So in particular, I've pulled out the pain recommendations. There's a much bigger document for all kinds of other things. But in terms of lymphedema, there's adequate evidence to recommend low-level laser therapy, manual lymph drainage, and compression bandaging. When it comes to peripheral neuropathy, there's no recommendations of comp therapies, but there is a recommendation of what not to do, because anecdotally we know, and in the evidence as well, we know that lots of people use complementary and integrative therapies, some of which don't have evidence to support their use. And one that has been popular in, blogs and on the internet is acetyl L-carnitine. But there have been enough studies done that they can categorically say this is not recommended, in fact may worsen neuropathic pain. For pain more generally, the integrative therapies that show up with the highest levels of evidence are acupuncture, healing touch, which covers a number of different touch-based modalities, hypnosis, and music therapy. And we'll go into these in a bit more depth shortly. And for fatigue, which often goes along with a pain situation, hypnosis also has reasonably good quality of evidence. Ginseng is one of the only herbal remedies that we'll mention today that has low level but a good record of safety. So low level evidence, it's not super effective, but it can help and it doesn't cause harm as far as we know so far for fatigue. Acupuncture again can help with energy, and so too can yoga. And there is again a growing body of evidence around yoga in breast cancer populations. So the Society for Integrative Oncology summarised the research on integrative medicine for pain management in oncology, and ASCO, that big authority in the US, accredited it, so gave their support to these guidelines. And so this is the summary slide, I guess, for all the things that we will talk about today. It's an at-a-glance guideline for the recommended interventions. So there's certain kinds of medications that people might be on that increase pain, such as aromatase inhibitors. So that's a hormone balancing or blocking treatment. And one of the side effects commonly is joint pain that can be quite debilitating. So you can see there the quality of the evidence and the strength of the recommendation. Acupuncture has had enough studies done that have shown good effectiveness that there's intermediate level quality there and a moderate strength of recommendation. Yoga can certainly help with joint pain, but the evidence quality is lower. That's partly because of the way the studies have been done and designed. And there's a lot of heterogeneity as well. The different types of yoga make a difference. So there's a weak recommendation there for yoga for joint pain. General cancer pain, you can see there's evidence for acupuncture, reflexology and or acupressure. If you're a body worker, you'll know that these are two different disciplines. However, they're often bundled together in the research. It's part of the problem with research into complementary therapies. There's a lot of work still to be done in this space. Similarly, massage as a kind of umbrella term has a moderate strength of recommendation. Hatha yoga and guided imagery with progressive muscle relaxation is there as well, though the evidence quality is low, and so the strength of recommendation is weak. For chemotherapy-induced peripheral neuropathy, acupuncture, reflexology and acupressure show up, but again, low evidence quality and a weak recommendation. For procedural pain, so this is having things like biopsies, radiotherapy, surgeries, all of those things that are intrusive and uncomfortable, maybe even blood tests, depending, on your level of sensitivity to these things. Hypnosis has quite a high level, an intermediate evidence quality and a moderate strength of recommendation. For surgical pain, acupuncture or acupressure and music therapy have been studied with low evidence quality. And for pain at the end of life, massage has intermediate evidence level quality. A little more now on different types of cancer-related pain. So I mentioned procedural pain. That's certainly something that can provoke more of that kind of nervous system stimulation, that fear and anxiety. Some people talk about scanxiety, which is a related but slightly different idea, that you get more anxious when you're heading in for scans and checkups, and obviously receiving results when there's a time lag can be a very nerve-wracking time. But during those actual procedures where there might be pain related to the procedure, calming the nervous system can be really helpful. Bone pain due to metastases, that's something that we, again, can't necessarily treat with complementary therapies, but may be able to help you manage. Joint pain I've mentioned already. A classical kind of example is the aromatase inhibitor-related joint pain, but you could also have a comorbidity of arthritis. There could be joint pain from swelling and inflammation for all kinds of other reasons too. If you have mets to the liver, there may be pain in the liver and the liver may swell. We've mentioned this peripheral neuropathy a little bit and lymphedema. And these are the main risk factors for pain for people with breast cancer, is lymphedema, which we know affects around 20% of people treated for breast cancer. Having a higher body mass index, we are all about a shame-free approach here and body acceptance, but it is true that having a heavier body weight can increase the experience of pain. There's a few different factors to that. Some of it is biomechanics, there's more load on your body, but other parts are hormonal. Fat tissue generates some inflammatory cytokines that circulate in the body. So there's more pain typically for bigger bodied people. Lower levels of education are also a factor for pain, and this might speak to that idea of less health literacy, not really necessarily having skills or knowledge on how to deal with it. But of course, we know that school-based education isn't everything, and you can always be a lifelong learner. If you've had axillary lymph node dissections, that increases your risk of pain. Chemotherapy increases your risk of pain. So too do hormone therapies and radiotherapies. And this comes from a 2017 systematic review and meta-analysis. In one of our earlier webinars, we kind of talked you through the hierarchy of evidence. So if some of what I talk about in terms of the strength of research is unfamiliar, you might want to go back and watch some of those earlier webinars. So a little bit more on lymphedema, because this is a relatively common experience. It's most common in the first 12 months after treatment begins, but it can pop up at any time for anyone with breast cancer. It can occur after treatment for breast cancer when lymph nodes are removed. So you can see there that there's less drainage points for the lymph channels in the upper limbs if those lymph nodes are removed in an axillary lymph node operation. It can affect the arm or the chest after the treatment of lymph nodes. The way that it feels, well, you may have experienced this, so I don't need to tell you, or you might be a health professional who works with this, so I don't need to tell you. But for those who aren't sure, it can feel like a sense of heaviness, tightness, or fullness. The tissue swells and the skin gets stretched. If you're wearing jewelry, it might get tight. And then that body part starts to ache or is painful or feels tense. A test of whether there's edema is you can press your finger in, and when you remove it for after 30 seconds, the dent remains. So that tells you that it's not fat or normal body tissue, it's lymphedema. So early education and ongoing monitoring, and again, you want to speak to your relevant health professionals, which can include your massage therapists, your physiotherapists, your breast cancer nurses, and oncology professionals. The chemotherapy-induced peripheral neuropathy, I also mentioned before, is a very, very uncomfortable situation. It's caused by damage to the peripheral nerves, typically by chemo, but can also be from radiotherapy as well, and can also happen not necessarily related to breast cancer, but in diabetes. So when there's high levels of circulating blood sugar, which again could be a comorbidity with metastatic breast cancer. The symptoms can really vary with peripheral neuropathy. Sometimes it's numbness, and that might sound not that bad, except that it does then put you at risk of falling or injuring yourself if you can't feel what your hands and feet are doing. It can also really have a big impact on your well-being and your quality of life if you can't do the things that matter to you, like perhaps anything with fine motor skills, handwriting, knitting, sewing, cooking. These things can be affected when you have neuropathy in your hands and in your feet as well. There can be weakness through the limbs if the whole limb is affected, a feeling of pins and needles, which I'm sure you know can be really uncomfortable, can be hot or shooting kinds of pains. And again, there's a risk there of not being able to be sensitive to temperature. So you might get injuries related to excess heat or cold. And then the question always comes up about fatigue. It goes hand in hand with pain, but also other aspects of the breast cancer experience. Fatigue is the most common complaint. It's an unmet need in the medical system. Everybody feels tired when they're going through treatment, but even if you're not having active treatment, energy levels can feel really low. And the definition of fatigue is when you're too tired to engage in daily activities. So it might be a side effect of treatment, again, those kind of inflammatory situations that treatments cause. It can be the exhaustion of going to lots of appointments all the time and being engaged in the system. It can be due to coping with pain. A lot of energy goes into trying to cope with pain. There can also be other situations like a low blood count, lack of red blood cells, stress, anxiety, depression. These all go hand in hand with pain. It can be to do with not sleeping well. So if you have pain, that often interrupts your sleep, can be difficult to get comfortable or difficult to stay asleep if pain wakes you. And fatigue can also be a side effect of medication and, ironically enough, including medication that you take to reduce pain. So we get into my area now, managing these symptoms with complementary and integrative medicine. It's important to note that a large percentage of people with cancer, this is across all cancer types, use what's sometimes termed CAM. I'll talk you through the different terms in a moment. But less than 20% of those users of complementary therapies consult with a suitably qualified health professional. That means they're self-prescribing, often based on hearsay and anecdotes and Dr. Google, which we know can be misleading, if not dangerous. So these terms have been used interchangeably over the years, but they are somewhat different. So complementary and integrative medicines or therapies are things that are used alongside conventional medicine, things that your oncologist won't have a problem with you using if there's no known interactions and there's an evidence level there that shows that these can be used safely. Alternative medicine, though, is something different. It's something that's unproven And so that doesn't mean that you cannot ever choose something alternative. We know that science is kind of catching up to traditional understandings of how to use different plant medicines, how to use the mind, how to use, things that occur naturally. So science hasn't got there necessarily with everything that's out there. But if there's no evidence, then you really are running some risk that there could be interactions with conventional treatments, or that you might be wasting your time, your energy, your resources, chasing after things that might promise a lot, but there's no evidence to suggest that they will. So what we focus on at Breast Cancer Care WA, and what is a big kind of global movement, is integrative oncology. And this means treating people as the important person in the centre of the care, so it's patient-centred or person-centred. It's evidence-informed. So even where you see that there might be a fairly low level of evidence, or the evidence that's there isn't really very rigorous, isn't that well studied yet, at least if there's some evidence, we can call it an evidence-informed field, utilising mind and body practices, natural products, and/or lifestyle modifications that come from a variety of different cultural and ethnic backgrounds, different traditions, and these are used alongside your conventional cancer treatments with the aim to optimise health, quality of life, and get the best possible outcomes across the whole cancer care continuum. What's important about integrative oncology is that it's really empowering, because so much of what happens in the biomedical model can feel like it's done to you. This is something different. This is something that you can then focus on for yourself, that you can do for yourself before, during, and hopefully beyond cancer treatment. So you'll see in the literature these abbreviations: CT for comp therapies, CM for complementary medicines, CIM for complementary and integrative, so that's the somewhat proven stuff. CAM indicates that some of it is unproven, there's alternative medicine there. IM is also used to summarise integrative medicine, and IO for integrative oncology. There's lots of different types, and again in our first webinar we went into these in more depth, but there are biologically based approaches. These are the ones with the greatest risk of interacting with conventional medicine. The dietary changes, especially extreme diets, carry some risk. It's always good to have a healthy diet though. Herbs and vitamins in potentised forms can become a risk of interactions there as well. There are the body-based therapies, or the touch-based things, mind-body interventions, energy therapies, which are much harder to study and harder to prove, so there's less evidence around them, but they probably don't do any harm. And then there are the full-blown alternative medical systems like homeopathy, naturopathy, Ayurveda that you might come across, and they kind of have their own philosophies and scope of practice and treatment modalities within them. So this is a nice way to think about your integrative medicine. You can do a bit of all of it, whatever appeals to you, whatever is appropriate to your circumstances, keeping the conventional medicine involved, including drugs and surgery and other interventions, as well as bringing in then some nutritional, some natural, some psychological and physical practices. So overall, we try to look for these systematic reviews, because a systematic review brings together lots of literature. In preparing this webinar, Mel and I have looked at lots and lots of journal articles. This 2020, so fairly recent systematic review, covered 46 included articles, which meant there were 3,685 people studied. That's going to be a statistically significant number. And the effect of CAM interventions, so they included things that might be considered alternative, on cancer-related pain in breast cancer was studied. And the authors found the following modalities improved cancer-related pain: acupuncture and acupressure. Again, they're bundled in together, even though they're different. They're working from the same philosophy. Tai Chi and Qigong, similarly. Hypnosis, meditation, including mindfulness, that always gets bundled in together. Music therapy, yoga, massage, reflexology and Reiki. Again, they're different things, but they get summarised together quite often. It was interesting to note that in this particular systematic review, aromatherapy had no effect on cancer-related pain. Now, if you are a big advocate for aromatherapy, you might be going, that's not true, I've seen it work. Anecdotally, definitely, and in some other studies, it has shown up quite well. But when you summarise all of the data, aromatherapy didn't show up as being particularly helpful for cancer-related pain in breast cancer patients. Doesn't mean you can't use it, but means that there's not a lot of evidence for it. A little bit more around management of lymphedema. So there's lifestyle things here. And I think this is important to note that using the limb as normally as possible is the first recommendation. And that really speaks to this idea of living well with pain, that we don't want to stop moving. You know, lymph is a kind of mechanical example of things getting worse when we freeze up around them. The lymphatic system doesn't have its own pump, so it needs us to contract and relax our muscles in order to move lymph around the body. Of course, you want to minimise the risk of scratches and injuries to any affected limb because there's a greater risk than usual of cellulitis and other infections. So stay moisturised, cover up, don't get sunburnt, all of that good stuff. Refer to a qualified lymphedema practitioner. And you can't go wrong getting strong. Lifting weights has been proven to be not only safe, but also effective. But as I mentioned earlier, if you have metastatic breast cancer, you may want to do that under supervision. So the program is tailored to you. If you do get an infection related to your lymphedema, it needs immediate treatment. You can't let it run. Laser therapy has some evidence. Compression garments can be useful. Looking after the skin. And then we're going to move more into our complementary therapies, including mindfulness and yoga. So the first complementary therapy we're looking at here is music therapy. Music therapy is available in some hospital settings and cancer wellness centres. It can be both passive and active. So it's separated into two divisions. Music medicine is where you listen. You might listen to your favourite songs. You might have someone come and play an instrument and play songs that speak to you in a certain way that bring up good memories. But then there's also music therapy where you're engaged in creating music, and that can be particularly powerful if that's your thing. These music-based interventions have been shown to decrease anxiety, depression, pain, and improve quality of life. Music therapy interventions are particularly effective for anxiety. And greater reductions of anxiety and depression are observed in breast cancer populations than other tumour types. So that's good to know. People who are admitted to a hospital ward and then get to do music therapy, music therapy involving people admitted to a hospital ward is less effective in improving quality of life. That's probably because you're in the hospital. So if you get to do these things, you know, in different settings, in more natural settings or in your home, that's ideal, but it's still worth doing if you are in a medical setting. I've mentioned acupuncture a few times. Acupuncture can be practiced by traditional Chinese medical practitioners and also by physiotherapists and other health professionals who've had the appropriate training. Again, a fairly recent systematic review and meta-analysis of patient-reported outcomes has been published in 2021. There were 29 studies that met the inclusion criteria. And the end of treatment measures showed that patients reported less pain when they'd had acupuncture, less hot flashes related to menopausal symptoms, decreased fatigue, improved sleep, and decreased anxiety. Sounds good. Sounds like something that you would want to do. Cochrane reviews are notoriously conservative. They only look at randomised controlled trials, which is only one way of doing research, and it's a particular approach to research that doesn't always work that well when it comes to complementary and integrative therapies, which are so kind of multi-dimensional. So we take it with a pinch of salt, but it's still really interesting to see what comes out in a Cochrane review. So this was a review where they found 5 randomised controlled trials of acupuncture for cancer-related pain, with a total of 285 participants. Across these 5 studies, when they crunched the data, they found that acupuncture was superior to sham acupuncture. So that tells us that it does matter, that you're following this philosophy, these meridian lines, these acupoints may have meaning. and it was superior or equivalent to oral medications that were administered according to the World Health Organization analgesic scale. So that's pretty good. It's as good as or better than some of the pharmacological treatments. So I mentioned this a little bit already. I'm hinting at this paradox of avoidance because it's something we all live with. It's really normal to want to avoid pain and seek pleasure. And even as you're sitting and listening to this, or maybe you're moving around, you'll be changing the way that you position your body to avoid discomfort and seek comfort. When you have pain, people will do almost anything to get away from that pain, including emotional pain. We numb ourselves or we avoid. It's how we seek comfort. But if you think about that map of the body and the brain, it's paradoxical because what we avoid tends to get reinforced by our thinking and our behaviours. So we're thinking then that mindfulness is a really important strategy that helps us kind of stop avoiding, stop running from our suffering, open to that discomfort, and hopefully in doing so reduce our perception of pain. There's a lot of different mindfulness-based interventions. Some are more psychological and some are more movement-based. Of the movement-based practices, yoga, tai chi, and qigong are the most studied. They all have in common this intentional connecting of the mind and the body, using the breath as this kind of anchor to the present moment. Yoga has the most evidence, it's been studied the most, but all of these mindful movement practices can be beneficial. So again, people can choose, they can follow what appeals to them, what is a good fit for their culture and belief systems. The benefits include improved balance, which means the risk of falls is reduced. This is especially important if you have bony mets because falling can be a big risk for you. So improving your balance through these practices is a great idea. No matter how they study these mindful movement practices, quality of life always seems to show up well. It improves. Sleep is improved, digestion, less fatigue. Lymphedema can be managed. And so there's been some really good yoga studies on lymphedema management, and pain can be managed better. In the lymphedema studies by Annette Loudon and her colleagues, yoga has been shown to decrease the tissue density in the affected upper arm, to decrease pain, especially pain that limits activity. So that's important. It means you can carry on doing the things that matter to you. Yoga might be one of your strategies for how you manage to do that. There's increased pelvic stability, particularly when it comes to lateral flexion, so that's side to side bending, which speaks to the mind-body connection. You know where your body is in space, your proprioception is improved. There's an increase in the range of motion for not only the affected limb, but also the non-affected arm in flexion and abduction. So raising the arm up or taking it out away from the body. And improved symmetry between the two limbs in these actions. Another thing that helps with the movement of lymph, but also triggers the relaxation response. And if you're someone who's interested in things like polyvagal theory and the vagus nerve, one of the best ways to kind of hack that system, to shift us from stress mode and sympathetic nervous system dominance into the rest and relaxation mode of parasympathetic dominance, where all of our kind of defenses and hypervigilance can drop and we can feel safe to inhabit our bodies, is diaphragmatic breathing. It's simple, it's accessible, you can do it right now, you don't need any special gear. You can see there that the diaphragm is this big umbrella-shaped kind of band of muscle underneath the rib cage or underneath the lungs. And when we inhale, the diaphragm presses down towards the organs of the abdomen. And when we exhale, it rises up like that kind of dome shape under the rib cage. So slow diaphragmatic breathing is like giving ourselves a massage. It improves lymphatic flow. It's also been shown to decrease lymphedema volume in affected limbs, and it triggers the relaxation response, particularly if you extend the exhale. So there's this kind of balance all the time in our nervous system. Our inhalations are a little more stimulating, our exhalations are a little more relaxing. So long extended out breaths help trigger that relaxation response, which tends to help everything, really. Yoga has been studied extensively in lower back pain. So again, it's only one kind of pain that you might experience in metastatic breast cancer, but it's a really common kind of pain. And if we're sedentary for various reasons, it's even more common. So when they did a systematic review and meta-analysis of yoga studies for lower back pain, they found strong evidence for short-term improvements in pain intensity, less functional disability, and a global improvement. Everything got better. Strong evidence for long-term effects on pain. And what's interesting in the yoga studies is, although, dose matters and the more yoga you do, the more response you're likely to get, it also tends to last when they do follow-ups. Sometimes they follow up 3 months, 6 months later, and the effects of having done a series of yoga practices can be lasting. So the message is, do what you can. A little bit goes a long way. And if you can do a small amount regularly, then you might have a real impact on your pain. And also importantly, there were no adverse events. There is, of course, a small risk of fall. There's always a small risk of injury in any physical activity. But in these studies, there was no adverse events. Yoga has been found to significantly reduce pain, greater than various control interventions, including standard care, self-care, other forms of exercise. This is comparing more active yoga with more relaxing yoga and suggesting that the more active yoga has a better impact. It's also been shown up to be more effective than touch and manipulation, like physio-type manipulations. And again, this is a systematic review. It's a bit of an older one, 2011, but it was good because they pulled together lots of different pain types. So not just cancer-related pain, but also arthritic pain, carpal tunnel syndrome, migraines, labour pain, etc. They found that they could get 10 good quality studies. And if they repeated this, they'd find even more good quality studies, because that was a long time ago now, 11 years back. Another important thing about the movement modalities, including yoga, tai chi, qigong, and exercise, is that it's the best thing you can do to intervene in the cycle of fatigue and sedentary lifestyle. It's another of those counterintuitive things. You feel tired, so you think, I should rest. But sometimes the more you rest, the more tired you feel. We need to step it up sometimes, because exercise stimulates new neural pathways in our brain and facilitates connections in our brain. It breaks that fatigue, rest, greater fatigue cycle. And it can include all kinds of things, including gardening. Again, be careful if you've got lymphedema, use your gloves and cover up. But anything you can do that moves your body, and particularly if you care about it, if you like it, if you enjoy it, if you do it with friends, so much the better. Another thing to think about with fatigue is delegating. Even though movement and exercise are beneficial, you don't have to do it all. You can ask other people to do some of the chores that you don't want to do. Sleep management is tricky, we know, but important if you can have better sleep. And of course, your nutrition comes into that, as well as hydration. So exercise is good medicine, and you can't go wrong getting strong. That kind of resistance work, like you see in the image there, with resistance bands or therabands, or lifting suitable weights for you, aids bone mineral density, normalizes your digestive hormones, the leptin and ghrelin that govern how much you want to eat and when you feel full. Exercise can also improve your sleep. It decreases pain. It improves fatigue, peripheral neuropathy, lymphedema, and your mood. The recommendations for people with breast cancer are 150 minutes of moderate intensity, or more if it's lower intensity. So 150 to 300 minutes per week of moderate intensity aerobic activity, 75 to 100 minutes of that being vigorous, or an equivalent combination of each. You can do it in any kind of episodes. So sometimes I think a daily practice is a good idea. 30 minutes, 5 days a week would get you 150 minutes. Of those exercise sessions, 2 of them should be muscle strengthening, so resistance type exercises, and you need to include some balance training. So a strength circuit, a high intensity or maybe not so high intensity, depending on your situation, cardio type exercise, some yoga, things that you enjoy. can all be built into your lifestyle. It is important to note when there's bone mets that higher impact exercises may not be safe initially. They do help to improve bone density, but your risk of fractures or spinal compression is higher if you have bony mets. So this is where you want to see an oncology trained exercise physiologist or physiotherapist, and you can access that kind of care through the Medicare Chronic Disease Management Plan if you go and ask your GP for a referral. So getting back to the more mindful stuff, there's also been really good evidence for mindfulness-based self-compassion practices. I don't know about you, but my self-talk is sometimes quite mean. If you start listening to the things that you say to yourself, sometimes we're our own worst enemies. We don't offer ourselves the kind of supportive messaging that we would offer a dear friend in the same situation. So this is an incredibly powerful skill that you can learn to give yourself self-compassion. A recent randomized controlled trial from 2021 showed that for people with pain, mindful self-compassion is more effective than cognitive behavioral therapy. It increases your self-compassion, it increases your pain acceptance. It's helpful because it doesn't let pain interfere in your life as much, and it decreases your catastrophizing thoughts and anxiety. So how do you do it? Well, first you have to find that space of mindful self-awareness. Observe when you are suffering. So when you feel the pain experience arising, instead of avoiding it, numbing it, trying to escape it, it's an allowing, it's being aware. Yes, this is suffering. I am suffering. And even just acknowledging that can be really powerful. And then recognizing that everybody suffers, not the same as you. It's not a competition. But these are experiences that are a normal part of being human. They're suffering in humanity. It's part of the package deal. And then offering ourselves kindness, asking, what do I need? What is in my own best interests here? Can I help myself? Can I give myself exactly the kind of kindness that I would give a friend? Maybe that self-kindness means you're going to book yourself a massage, because massage shows up really well in the literature. In a 2016 systematic review of meta-analysis, there were 12 high-quality and 4 not-so-high-quality studies included. The results demonstrate that massage therapy is effective for treating pain compared with no treatment and compared with active comparators. So massage therapy compared with active comparators might be things like physiotype manipulations, and massage therapy was found also to be beneficial for treating fatigue and anxiety. And we know that the interaction with health professionals is part of that. So you want to find someone that you feel a real sense of safety and kinship and trust with. Reflexology, you might have seen that old chart. I had that old chart on my wall for many a decade. There isn't any evidence that that exact idea is true, that the body is mapped on the soles of the feet. However, it doesn't really matter whether that's true or proven or not, because there is some proof that this experience of foot massage, of reflexology with intent to heal, is powerful medicine. A 2019 systematic review, which again bundled a few different things together, bundled aromatherapy, massage and reflexology together. They studied 5 qualitative studies, so they analysed the themes in them. And they identified 3 different themes. That the experience during the therapy was important. So that includes the whole kind of sensory setup, the space that you're in, the music, the smells, the lighting, the care that is shown. It enhanced well-being and escapism. So it's kind of the opposite of what I've been talking about. Instead of leaning into your suffering, this is a kind of leaning into a holiday mode, treating yourself nicely. The benefits extended beyond the therapy session, so there were lasting benefits. And the delivery of this complementary therapy is also very practical, including in palliative care. People don't need to get out of bed for this therapy. So the conclusion is that people with advanced cancer can experience benefits from aromatherapy, reflexology, and massage, including enhanced well-being, respite, and a bit of escapism from their health situation. Acupressure draws on the same knowledge and philosophical system as acupuncture, and this is either done by a therapist to you or you can self-administer acupressure. It can be a range of stimulating a single point or a combination of points. And in oncology care, acupressure is often used for chemotherapy-induced nausea and vomiting, as well as pain, stress management, and fatigue. Excuse me, that's what happens when I talk so much. Moving into hypnosis now. It might not be what you imagine it to be. Clinical hypnotherapy or hypnosis is increasingly evidence-based. It's not getting people to get up on stage and quack like a duck or anything like that. It's more like a relaxation approach whereby the therapist helps people to change some of those thought patterns and self-talk. In a systematic review of 21 studies, 11 of which were randomized controlled trials, self-hypnosis, so people doing it for themselves, provided pain relief in cancer patients and at the end of life. Another systematic review of 27 studies, only one was a randomized controlled trial, so that means the evidence is a little weaker, and it's also quite an old study, concluded that the poor quality of studies evaluated and the heterogeneity of study populations limited further evaluation. A meta-analysis of 37 studies, where there were over 4,000 people involved on all psychosocial interventions, including hypnosis, concluded that these modalities have a significant medium-sized effect on both pain severity and pain interference with functioning, and that quality-controlled psychosocial interventions should be considered as a part of multimodal approaches to pain management in cancer. Some more recent work, a systematic review of randomized controlled trials done in breast cancer, showed that hypnosis positively influenced pain from diagnostic breast biopsies. So we talked about that procedural pain experience. This is showing that hypnosis can be effective to help you deal with that kind of pain, including breast cancer surgery, radiotherapy, and metastatic related pain. Interestingly, patients who are highly hypnotizable reported greater benefits from hypnosis, used self-hypnosis more often outside of group therapy, and applied it to manage other symptoms in addition to pain, which indicates that not everybody is hypnotizable. And so it's, again, something that you can choose for yourself. You can try it out. If it's not for you, that's fine. A note about herbs and supplements. There isn't a whole lot of strong evidence to support the use of ingested dietary supplements or plant-based medicines as supportive care or to manage breast cancer treatment-related side effects. I mentioned earlier there's some evidence for ginseng. It might be suitable in fatigue, but it's low-level evidence. Something else that people often find that they choose because they've found it on the internet or someone like a naturopath has recommended it is PEA. This palmitoyl ethanolamide has been studied quite a bit actually, 16 clinical trials, 6 case reports and a meta-analysis. And it's been found to be safe, so that's important, and some efficacy has been shown. So it may help you with pain and it's probably not going to interfere with other treatments. So that's something you could consider. And I'll note again, though, that acetyl L-carnitine is not recommended for peripheral neuropathy because there has been potential harm found from that. If you're thinking about taking a herb or a supplement, it's important to see someone suitably qualified. Don't self-prescribe. And again, our previous webinars, we've talked about, the labelling and the TGA oversight that can occur in Australia. Another good resource there is the Memorial Sloan Kettering website where you can look up specific herbs and supplements. They're very well researched on that site. Another more psychological approach that I've touched on today is ACT, Acceptance and Commitment Therapy. What's significant about ACT is it doesn't aim to reduce pain, but instead it aims to help you live well. It aims to increase psychological flexibility. In a systematic review and meta-analysis of 11 trials, they found that ACT was favoured over controls, which meant no alternative intervention or just treatment as usual. Significant medium to large effect sizes were found for measures of pain acceptance and psychological flexibility, which are considered the processes of ACT. There were also significant small to medium effect sizes found for measures of functioning, for anxiety and depression. So ACT is an important strategy, and our counsellors typically use that quite a bit here at Breast Cancer Care. What is it? Well, it's a process. It's a journey you can take. It's personalised, it's tailored to you. But the essence of it is getting in touch with the present moment, so it's mindfulness based, and then identifying what matters to you, your values, and they can change. And then deciding, what do I want to do? How will I enact my values? You get to that by observing yourself as that detached observer, by unhooking from the thoughts that you might typically be habituated into, and by opening up to allow suffering and joy in equal measure. And the aim of ACT is to maximise your potential for a rich and meaningful life, no matter what that life is throwing at you. One of the questions that an ACT practitioner might ask is the magic wand question. If I could wave a magic wand and take away your pain, what would that look like? How would you want to live your life if pain was no longer an issue? And of course, we don't really have a magic wand. We can't take it away, but the question helps us to kind of unveil, well, these are the things I wish I was doing, or these are the things that matter to me. And then the invitation is there. Can we be creative? Can we find a pathway to do those things that are meaningful with pain if we can't resolve the pain? Whereas John Kabat-Zinn said, you can't stop the waves, but you can learn to surf. Just in finishing our session today, we've got a number of resources for you. When the webinar goes up on the website, you'll be able to come back to these. But if you're interested in more of that pain science, the Explain Pain resources from Lorimer Mosley and David Butler can be found on the Explain Pain website. And there's also another site for the NOE group, the Neuro Orthopaedic Institute of Australasia, and they have some great videos and books and different things you can learn from there. The integrative oncology resources that we've touched on today include the Memorial Sloan Kettering Cancer Centre website and the Society for Integrative Oncology. If you're looking for more information about peripheral neuropathy, there are some fact sheets available from the Cancer Council and Everq and other resources online. Similarly, with fatigue, BCNA has a great booklet, the Cancer Council has a fact sheet, and the Australian Cancer Survivorship Centre also has a fact sheet. For lymphedema, you may want to go back, if you're being treated in a hospital, to the physiotherapy service in a public hospital or a private hospital. You can also look at the Australasian Lymphology Association, and you can search for a lymphedema practitioner in your area. If you can't find what you're looking for, the Cancer Council's helpline on 13 11 20 is always a great resource. They keep up to date with what's available in the community. And you can also have a look at BCNA for their lymphedema info. There are a number of exercise programs in the community, including the one through the Vario Health Clinic at ECU. Cancer Council can point you towards enrolment in that. The Pink Crusaders at Curtin. Lacking on here is Encore. Actually, the YWCA Encore program is a water-based exercise program. You can do the Life Now yoga, meditation and mindfulness and Tai Chi programs. They run on a term-by-term basis in different locations and also online now. I've got lots of slides here with the references. If you're an academic, you're welcome to source those. If there's something in particular that's taken your interest today, I'm happy to share our references. So I'm going to stop sharing that now, Mel.
And lots of great information there. Certainly for me, I know dealing with a lot of clients that I work with, pain can be a big issue for them. And often one of their biggest things is they don't want to take more medication because they're already on a lot of medication. And so they really want to look into these complementary and integrative therapies. So having the range there and the evidence behind them is really, really helpful. So thank you so much for that. There's no questions currently. I'll just have a fresh check. No questions currently, but if you do have any questions and you want to tap them in now, then just click on the chat icon. And as I said, that's often either at the top of your screen or the bottom of the screen, depending on what device you're using. And as Chandrika said earlier, we certainly at Breast Cancer Care WA, we have a number of resources available here as well to help with some of the things that we talked about today. So we do have counsellors here. We've obviously got myself, who you can talk to at any point about the resources that might be available to you, or if you want us to link into any of those programs that we were talking about. We run a number of workshops here which are based around mindfulness, such as clay workshops, calming the stress response, managing uncertainty. So anything like that that you would like to know more about, then just get in touch with us. You can either go to our website or you can ring the office 9324 3703 and they will direct you to the right person.